Good evening, everyone, and thank you for joining the National Pancreas Foundation webinar. We'll give it a few seconds for everyone to join. Good evening, everyone, and welcome to the National Pancreas Foundation's webinar. Tonight's presentation is Pancreatic Cancer, What's Cutting Edge in 2022. Please use the Q&A section of the portal to submit your questions. They will be answered at the end of tonight's presentation. This is a general patient question and answer opportunity. The National Pancreas Foundation provides hope for those suffering from pancreatitis and pancreatic cancer through funding cutting-edge research, advocating for new and better therapies, and providing support and education for patients, their caregivers, and healthcare professionals. Please consider taking an active role in furthering the mission of NPF by sharing your personal story, supporting our National Pancreas Bowl fundraiser, making a donation, or starting or joining a chapter in your local community. To learn more, visit our website at pancreasfoundation.org. And be sure to follow us on Twitter, Facebook, and Instagram. Together, we can provide hope. I'd like to welcome tonight Dr. Raul Pinella as our moderator this evening. Dr. Pinella serves as the NPF Arizona Chapter Medical Director and is Associate Professor of Medicine and a consultant gastroenterologist at the Mayo Clinic in Arizona. He is the director of the Pancreas Clinic and the Endoscopic Bariatric Therapeutics Program at the Mayo Clinic in Arizona. His research interests include the pancreatobiliary diseases and endoscopic bariatric therapies. He is a member of the ABE Advisory Board and the Vice Chair of the Education Committee for the World Endoscopy Organization. Thank you, Dr. Pinella, and all of our panelists, Dr. Stucky, Dr. Kachaamy, and our patient volunteer, Dakotah Perry. Welcome, Dr. Pinella.
Thank you so much, Trish, and welcome to everyone. And it's a real pleasure to be here as a representative of the National Pancreas Foundation and to be hosting this for a disease that is obviously very close to our heart. And the theme of today is pancreatic cancer, what's cutting edge in 2022. So we wanted to use this session as a sort of a window into what's really state of the art for pancreatic surgery and for endoscopic interventions in pancreatic cancer. So we have a really stellar set of physicians who are speaking. We also have a very special guest that I will introduce in Dakotah Perry. So without further ado, I think the way we will do it is we'll first start with a talk by our panelists. Actually, we'll first start with a sort of an introduction by our patient representative, Nurse Perry, and then we'll go into the presentations, and then we'll want a really robust Q&A. So please get your questions. My hope is that we will have a really interactive session. So let me first start by introducing our physician panelists, and then I'll introduce our patient representative. The first talk will be by Dr. Stucky. Dr. Stucky is a very dear colleague here at Mayo Clinic. She's a surgical oncologist here at the Mayo Clinic in Arizona. She received her undergraduate and medical degrees from the University of Kansas and then completed her general surgery residency here at Mayo Clinic in Arizona. She then went on to complete a fellowship in complex surgical oncology at the University of Texas MD Anderson Medical Center, and then came back, fortunately, to join us here as a colleague at Mayo Clinic in Arizona. She works obviously very closely with the multidisciplinary pancreas team and for hepatobiliary and pancreatic cancers and patients with pancreatic endocrine tumors. Her primary focus of research includes translational studies for pancreatic cancer and also for surgical ergonomics. Our next speaker is Dr. Toufic Kachaamy from the Cancer Treatment Centers of America, or City of Hope now. Dr. Kachaamy finished his training in therapeutic endoscopy here at Mayo Clinic in Arizona, and since then has been at cancer treatment centers where he's been really instrumental in furthering treatment of cancer care, and especially in terms of endoscopic treatment. He's the director of gastroenterology there and an enterprise clinical leader in gastroenterology. He's really passionate about high quality care, research, and innovation, and has really pioneered endoscopic palliation and the field of what we call endoscopic oncology in gastroenterology. So he's really at the forefront. He's also a very avid innovator and has been won the national Shark Tank competition in gastroenterology, which is a big honor. We look forward to his talk on endoscopic interventions. And now I'd really like to introduce Nurse Dakotah Perry, who has kindly joined us. He's from Winston-Salem, and he's a registered nurse in the critical care unit at Atrium Health Wake Forest. And in 2019, he was diagnosed with an early stage pancreatic disease, or high-grade dysplasia, as we call it. And he underwent a Whipple procedure, a pancreatic resection procedure, to remove the cyst from the head of his pancreas. For several years, he writes, he faced continued issues with weight loss and nutritional maintenance, but is doing wonderful now, 3 years out from surgery. So I just wanted to first start, if it's okay, with Mr. Perry really giving us an overview of his condition, what he went through, and then we'll go into Dr. Stucky's talk. So thank you again for joining. So Dakotah, I'll turn it over to you.
Yeah, thank you so much for having me. Hello, everyone. My name's Dakotah Perry. So, yep, as Dr. Pinella said, I'm a nurse here in Winston-Salem, but my journey with pancreatic cancer started back in 2019. I started to get sick around the Christmas timeframe, and by New Year's, I was seen in our local emergency department and ended up with a set of lab values that were quite abnormal. I had a lipase of about 15,000. And so was seen inpatient and stayed in the hospital for a couple days and had a workup and a scan. And initially they thought that I was dealing with something called pancreatic divisum. But my wife, who has dealt with this disease process twice before with her own mother, wasn't totally satisfied with that as an answer. So we went and got a second opinion, and sure enough, I had a very large tumor in the head of my pancreas. So at that time, I was also in nursing school. So between trying to juggle classes and eat the little bit of food that I could keep down and, the things that wouldn't make me sick, it was quite a struggle for about 6 months, because that's about the time frame it took to get a workup, to have an endoscopy, biopsies, and basically get prepared for surgery. So I had a Whipple procedure at the end of May, about a week after my semester ended, and then spent about 3 to 6 months basically recovering from surgery. I went through basically physical therapy, trying to lift weights and learn to walk again, because with the surgery itself, all my abdominal muscles had basically been cut. And so I was kind of tilted over. I didn't walk well. I was experiencing a lot of pain and was still dealing with delayed gastric empty, and dealt with that, I would say, for about 2 years. It's only been, I would say, maybe the past year that we've kind of turned a corner with that, with being able to eat a wider variety of foods and maintain a healthy weight. And basically for me, just to kind of finish introducing myself, I think the biggest thing in this journey was having support of both a good local university medical center and family, my wife specifically, who knew this disease process and advocated on my behalf when I just oftentimes wasn't feeling up to it, wasn't in a good mood or ready to make those decisions or ask for those things myself. So that's me. It's nice to meet everyone.
Thank you, Dakotah. That was great. And we'll circle back if you have questions, things like that. From a patient perspective, we'll address that in the Q&A. So now it's my pleasure to turn it over to Dr. Stucky for talking about pancreatic surgery. Thanks, Dr. Stucky.
Thank you very much, both for that kind introduction as well as to Mr. Perry for that really remarkable just talk that you gave. I'm very impressed with your story and really just thank you for sharing that with us. I was asked to give a talk about what's cutting edge in surgery for pancreatic cancer. So that's what we're going to talk about today. I don't have any disclosures, and ultimately I just wanted to say what my objectives really are. First, I wanted to talk about why we take a multidisciplinary, totally neoadjuvant approach to treatment of pancreatic cancer, and I'll explain what that means in a second. And then talk about surgical resection, specifically aggressive resections and outcomes. And then finally, talk a little bit about minimally invasive techniques and enhanced recovery programs. So I wanted to start with a story about a patient who I operated on in January of 2019. So don't worry, I'm trying to make this very basic. But I do like to have pictures with things. So this is your pancreas here, or this is this patient's pancreas. This is the liver, this is the gallbladder. And the patient had a mass in the body/tail of the pancreas right here, where that red circle is. He also had a disease called Charcot-Marie tooth. And because of that disease, he had a very difficult time with healing his wounds. So he actually ended up having a foot infection at the time that this pancreatic cancer was also diagnosed. And therefore, because he really couldn't take any additional medications that might render him more susceptible to worsening infections of the foot, we elected to go ahead and remove this tumor in his pancreas up front. He did very well with surgery. He didn't have any trouble at all. He got out of the hospital within just a few days. And everything seemed fine. The patient was started on chemotherapy after surgery because his foot had healed. But unfortunately, in just 6 months, the patient was noted to have a tumor in his liver. And sure enough, that tumor was biopsied and it was positive for a metastatic lesion in the liver. So why would I start with such a glum story? Well, unfortunately, that sometimes is the case with pancreatic cancer. It's the third leading cause of cancer death in the United States, and more than 50% of patients, when they're diagnosed, are diagnosed at stage 4 disease. So it's a very aggressive disease, and because of how aggressive it is, we're trying to figure out ways to treat this tumor aggressively as well. Because of the fact that so many people show up with stage 4 disease, it's led a lot of providers and physicians treating this particular disease to believe that there's something about pancreas cancer that causes it to spread quickly, and we don't know what that spread or what that cause is. But what we worry about is that we haven't seen the spread sometimes when patients present in this early stage 1 or 2 factor. And what is going to happen if we do a surgery like we did on the patient I just presented, but there has already been spread and we just didn't know it. So because of that, we've kind of changed our approach to how we treat pancreatic cancer. And what I mean by that is we provide an upfront neoadjuvant treatment. So what that means is we actually give chemotherapy to patients before we do any surgery. And the reason behind that is because there are multiple different studies that actually show that chemotherapy is the one thing that improves patient survival in every single stage of the disease, including stage 1, 2, or 3, or even 4. So chemotherapy is so important to us that we want to make sure that patients get it. and therefore we give it to them up front. A lot of people are very unsettled by that idea of leaving the tumor in place while they're getting chemotherapy. And so what I try to tell people is that by leaving the tumor in place, there are several benefits. First of all, if a patient were to develop worsening disease while they're on chemotherapy, well, then they wouldn't have benefited from surgery anyway, because surgery only treats what I can see. It doesn't treat what I can't see. And often what I'm worried about not being able to see is this micrometastatic disease. So cells that are on the microscopic level that have maybe spread and I don't know about it yet. So that way, if that happens during chemotherapy, I've kept somebody from going through all of the potential things that Mr. Perry went through for no benefit at all. The other thing is that if it might have spread, but just on the cellular level, that chemotherapy might be strong enough to treat that disease and potentially make it not ever come back. So even more reason to try to give it to the patient before the surgery has happened. And then lastly, but not as important to me, the chemotherapy will also obviously treat the tumor itself. And that might help us downstage the disease and maybe even make the surgery a little bit easier. Also, there are other studies that show that chemoradiation, or specifically radiation with a little bit of chemo to help enhance the radiation effects, does also provide a benefit for patients in the neoadjuvant setting, so before surgery. Recent studies have shown that not only does chemotherapy provide a benefit as far as margins are concerned, there's less positive margin, which is a good thing in surgery, but it also seems to help improve the rate of how many lymph nodes are positive too. And those are all really good prognostic factors. So again, when indicated, we really try to push for the chemoradiation to happen prior to surgery as well. Ultimately, at Mayo Clinic, like I said, we've taken on what we call a totally neoadjuvant approach, which means that we give chemotherapy first in some fashion, usually one of these two regimens that I have here. And while we're giving the chemotherapy, we're also following tumor markers so that we can watch to make sure that the chemotherapy is working, as well as something called a PET MR, which tells us how bright the tumor is and how active the cancer is. And what we're wanting to do is we're wanting to see both that CA19-9 and the brightness of the tumor to go down. If it doesn't go down, then we actually will switch the chemotherapy to try to push for a better response. After we get what we think is a good response, then we'll switch to radiation and ultimately surgery. So you can see right here, this is really what we're looking at, this trend of CA19-9 going from high to normal. That's a really good sign. And similarly here in the PET scan, we see that it's super bright and now there's nothing. Those are really good prognostic factors. And we know that these are good prognostic factors because sure enough, one of our main proponents of this type of therapy, Dr. Mark Trudy, is in Rochester, in Mayo Rochester, and he's actually reported our results from using this totally neoadjuvant approach. And what he's shown is that in 194 patients, the 5-year overall survival for patients who have had a good response to the chemotherapy and the totally neoadjuvant therapy is almost 5 years. So that's pretty impressive. That's certainly different than what we would have heard of, 20, even 15, 10 years ago. So that's really remarkable. And he continues to show that in patients who have a really, good response, meaning the CA19-9 has come down, or once the tumor is out on final pathology, it shows that there's really no tumor left because of the treatment before surgery, or in patients who have gotten more than 6 months of chemotherapy, those patients are the ones that have that up to 5-year overall survival. And in fact, those patients have, the more factors of the three that I just mentioned you have, the better your survival is. So all the more reason to push, because once we do, we know that, surgery might be worth it. So at this point, you're probably asking yourself, why is a surgeon spending so much time talking about chemotherapy? I thought that they cared about surgery. And the reason is because I feel so strongly that our advancements in neoadjuvant therapy have really been the result of us being able to do more aggressive surgical resections. Back again, 10, 15 years ago, we stratified patients' tumors based on how they looked on imaging. And what we stratified them into was upfront resectable, which I don't have here, borderline resectable, and locally advanced. And what that means is how much of the surrounding structures does the tumor involve? Usually when it was borderline resectable, we would say, well, we'll try to do surgery, but we might not be able to finish it. And in the locally advanced patients, we would say, not going to happen, don't even bother, and surgery wasn't ever attempted. But now what we're seeing is, because of the responses that people are having to chemotherapy and totally upfront neoadjuvant therapy, there are many more institutions, including Mayo Clinic, as well as my former institution of MD Anderson, that really are reporting their rates of success in patients who previously had borderline resectable or even locally advanced cancer. And this is successful surgery, that is. So now we're noticing that surgeons are being willing to be more aggressive. But again, it has to be worth it, right? So what we believe is, if you've had a good response to neoadjuvant therapy, well, then we're willing to go the aggressive route. And that may even include major vascular resections and reconstructions, which is what I'm showing here. This again is evidence from Dr. Trudy's practice. He is very well known for doing aggressive vascular resections when many, many other surgeons in the nation and maybe even in the world would otherwise say no. But he does it because of the fact that people and tumors really had a good response to the neoadjuvant therapy, and therefore he believes that it's worth it to try to be aggressive surgically. Certainly, aggressive surgery is not all fun and games. This is his results showing that there is a lot of morbidity, as well as even a substantial amount of mortality associated with these aggressive surgical resections. That said, there is definitely a learning curve related to these resections, and certainly I believe that his mortality rate is much lower than even when this was first published, because he was kind of a pioneer in the aggressive surgery, and it obviously takes some learning to really enhance what you're doing, and I'll talk about that in a little bit too. As for patients who might not necessarily, as for surgeons who might not necessarily be willing to do these aggressive vascular resections, there are some institutions that also will say, it may not be worth doing all this vascular reconstruction, but what if what we think is tumor around the vessels is not actually tumor after neoadjuvant therapy? And so maybe we should try to find out by biopsying this tissue around the vessels and seeing if it's tumor. And if not, then just preserving those vessels. That's something that I've actually taken that approach to, and I've had very good success with it. This is an example of a patient who had neoadjuvant therapy. She responded very well from a CA19-9 perspective. But on imaging, the reports kept reading that there was tumor involving these major vessels that she technically can't live without. So it would say, you know, abutment of the portal vein, which is a major vein going to the liver, and complete encasement of tumor around the common hepatic artery, which is the other major blood supply going to the liver. But to me, it didn't make sense if her CA19-9 was so impressively low after therapy, that would still be cancer. So we took her to surgery and biopsied these areas of fibrosis. And sure enough, wouldn't you know, she had almost a near complete response to chemotherapy and hardly any disease left over. And I will tell you, and no lymph node positivity after chemotherapy as well. So I will tell you, this patient I operated on in 2018, she's now 4 years out with no signs of recurrence. So, you know, she may be one of those patients that we actually were able to provide a cure for. So ultimately, my point is that we are doing more aggressive surgical resections, but only when it's appropriate in patients who have had a good response to chemotherapy. And certainly those patients who undergo major vascular reconstructions, they need a lot of resources, and it can definitely be done, but it has to be done at institutions that do it frequently because of the high morbidity rates. But that said, you know, there are other institutions that might not necessarily do the vascular reconstructions, but that doesn't necessarily mean that you're out of luck. You may end up not needing it after all. So, you know, that said, because we're doing a lot of aggressive vascular or, you know, work or aggressive surgery in general, we do want to make sure that we're setting up the patients for the best possible outcome. And so we need to be able to identify things that we can control at the time of surgery in order to make sure that patients recover readily. And some things that we've found is that we need to make sure we reduce our blood loss. We need to make sure that the patients don't have major fluid shifts at the time of surgery and then after, and do whatever we can to keep them from infections and get them out of the hospital. One thing that has become much more popular in our recent years is minimally invasive pancreas surgery, and that can mean either laparoscopic or robotic pancreas surgery. This is something that was really pioneered by another one of our Rochester colleagues, Dr. Michael Kendrick. He's probably one of the people who's done the most laparoscopic Whipples. And he and others have shown that oncologic outcomes in minimally invasive resections are equivalent. And then ultimately, once you get really, really good at doing these types of surgeries, there is a learning curve involved, obviously. We can reduce the blood loss as well as the hospitalization of these patients, but then improve their quality of life as well. Now, again, like I said, there is a learning curve, but because we have found such good success with the outcomes for these patients, certain societies have even pushed that, particularly in the pancreas lesions in the body and tail of the pancreas, these should almost always be removed via a minimally invasive approach when surgically feasible. So that's what we're all trying to push for. Now, that said, we definitely do minimally invasive pancreatic surgery at Mayo, but we do it as long as we don't compromise the oncologic benefit of the surgery. We do it under mentorship and proctoring as well. And we make sure that the most experienced surgeon only does it, particularly when they're really complex cases. So all that to say, we do these minimally invasive approaches often, but you should be wary of somebody who's really pushing for it in every circumstance, because that to me is more of a marketing tool. And at Mayo, we really try to be very considerate every single time we recommend a minimally invasive approach. So, you know, since we do a lot of complex pancreas cases, we can't always offer a minimally invasive approach. And therefore, we need to have alternative methods of enhancing recovery for our pancreatic patients. And basically what that means is we are starting to do enhanced recovery protocols that really are implemented to regiment how we manage patients both during surgery, even before surgery, and then after surgery. And as you can see, there are certain pathways that we follow that might be different than were even a few years ago. So for example, I've highlighted biliary drainage here in the preoperative setting. That's what's called a stent, which many patients will receive. About 15 years ago or so, there was a big New England Journal of Medicine study that came out saying that patients shouldn't get preoperative biliary drainage or stenting. And since that time, that theory has been kind of debunked, because we've actually found that by doing the drainage in the preoperative setting, it helps patients actually recover faster from surgery. Similarly, in the past, people have said, don't leave drains after surgery, definitely leave NG tubes after surgery, etc. And what we found is, again, by kind of changing how we look at those things, we're actually able to accelerate patients' recovery a little faster. I hope that we're starting to get better about doing things. Hearing Mr. Perry's talk, made me realize that we still have a long way to go. And what we think is, what's up to date, or, what's new practice, still might mean a lot of work for patients yet to come, but rest assured we are trying to work on it. So ultimately, I just wanted to highlight why we feel so strongly about doing neoadjuvant therapy, to show that because we've seen such an improvement in survival, we feel like we can be more aggressive surgically, knowing full well that aggressive surgery means a pretty significant recovery. And so we're going to do whatever we can, either via minimally invasive approaches or enhanced recovery techniques, to be with you, the patient, throughout the course of your care. So I thank you very much for allowing me to present today.
Thank you very much, Dr. Stucky. I think that was wonderful. And I think it's a tough disease, but I think that these new approaches and constantly sort of rethinking our approach is what gives hope in this tough disease. So we really appreciate your perspective, and we'll come back to the Q&A. So if you have any questions for Dr. Stucky, please put them in the Q&A, and we'll make sure to address those. Now I'll turn it over to Dr. Kachaamy, who'll talk about the endoscopic options, which hopefully will give you a perspective of what we can do to improve quality of life and help patients suffering from this disease. So, Dr. Kachaamy.
Yeah, first I want to thank Dr. Pinella and the National Pancreas Foundation for this opportunity. And Perry, thank you for sharing your story. Very impressive story, and story we hear every day. Dr. Stucky, fantastic talk. Thanks for the comprehensive talk and the overview. I was tasked to talk with endoscopic interventions in pancreatic cancer, obviously with focus from the patient's perspective. There's so many endoscopic interventions we have now that it's difficult to do a real comprehensive overview of it in 30 minutes. So I'm going to try to talk about some of the highlights of the things we do on a daily basis. And some of the stuff that I'm going to talk about is still somewhat experimental, and I'll highlight that in the talk. And would love to entertain questions at the end. These are my disclosures. And I want to talk a little bit about endoscopy. By definition, endoscopy is minimally invasive. We work through natural orifices with small tools, and the expansion of technology and the rapid improvement in technology has helped us do a lot more with a lot less. And you see on the left side the first computer, and obviously this is an iPhone or the Google Glass on the right side of the screen. And this is how much advancement we've done, and this has favored a lot of interventions during endoscopy, because there's a lot more that we can put at the tip of the scope or inside the scope to be able to do more. There's also some inherent advantage to working through natural orifices. The mucosa, which is the internal lining of the GI tract or the internal skin, heals a lot faster than the skin. I'm showing here a picture of a biopsy from a tongue wound 24 hours later. And if you compare it to a picture from a skin wound 24 hours later, the healing of the tongue is near complete at 24 hours versus the skin takes weeks to heal. Some of the advantages of endoscopy have to do with advancement in technology. Some of it has to do inherently with the way the body heals and the fact that endoscopy is done through natural orifices. Even when we get scarring after interventions, often the scar is not visible. And sometimes we have to go back and look at our scar quickly. If, let's say, we biopsy and there's cancer and we want to make sure we mark it. Because of this, there are many conditions that used to be managed surgically in the past that are managed now endoscopically. For example, ulcer and bleeding, colon polyps removal, bile duct stones, Barrett's treatment, early cancer resection, bowel obstruction, even obesity treatment, Dr. Pernell is something that he does every day, and cancer ablation. All of these have become more of an endoscopic approaches than surgical approach. Some of the other advantages of endoscopy is faster recovery from the procedures because it's a lot less invasive. And often when someone is on treatment with chemotherapy or systemic therapy, there's no need to hold the treatment for weeks to be able to do the endoscopic procedures. There are still major drawbacks for endoscopy. Often the interventions are smaller, more targeted, and they tend to be less durable than surgery. And of course, surgery is the only cure for pancreatic cancer that we know now. And this is why the aim of many of the treatments we do is to get the patient to Dr. Stucky so she can perform her surgery. And a little bit about the pancreas anatomy and why endoscopy continues to play a big role and will probably continue to play a big role in pancreas is the location of the pancreas. When you look at the pancreas, and this is a CT scan of the abdomen, and I highlighted the pancreas in yellow, and this is really, the pancreas sits in the center of the body. So anything you want to do to the pancreas, you either have to go through colon if you go through the front, or go through the liver. If you come from the right side, go through the spleen, or the kidney from the left side, and obviously it's not easy to go through the spine. So the location of the pancreas in the center of the body makes interventions from outside the body more difficult. Also the pancreas neighborhood is a very, very expensive real estate. It would be Boston if we're looking at real estate. The pancreas has the bile duct that passes in the head. It has the duodenum, which is the first part of the small bowel that wraps around the head. The gallbladder is very close to it. Major vessels, as Dr. Stucky showed in her talks, are often very close to the pancreas and get involved with pancreatic cancer. So anything you want to do to the pancreas can involve cutting other important organs. And versus when you tackle some problems endoscopically, you often tackle them from inside the stomach, where we're closer to the pancreas. Now, this kind of expensive real estate for the pancreas is the reason why pancreatic cancer has so many potential problems. And I'll talk a little bit in detail. When the cancer grows, which is what cancer does, it invades other organs. And having so many close organs to the pancreas cause a lot of the complications or problems with pancreatic cancer. Unfortunately, pancreatic cancer, when it starts inside the pancreas, because it does not invade other organs, is often asymptomatic, so no symptoms. And typically, as Dr. Stucky showed, when pancreatic cancer is diagnosed, it's often when it is more advanced in invading other organs. Some of the complications, as I said, can be explained really by the location of the pancreas. For example, a pancreas tumor here that is obstructing the bile duct will cause jaundice, something we manage endoscopically. A cancer that grows into the small bowel will cause blockage of the stomach or the exit of the stomach, what we call gastric outlet obstruction. Cancer in the tail often doesn't cause early symptoms and grows significantly before it causes local complications. And some of the endoscopic interventions that I'm going to talk about today are standard of care. And as I said, some of them are still relatively new, not available for routine clinical care, and might not be available for everyone, and have not been proven to make a difference, but are very promising. I'm going to cover endoscopic retrograde cholangiopancreatography, or what is known as ERCP, and that's work on the bile duct. I'm also going to cover luminal stenting, and I'm going to cover ultrasound guided or endoscopic ultrasound guided interventions. I will start by talking about ERCP. And ERCP is access to the bile duct or the pancreatic duct through the mouth. And typically we go through the mouth and then the stomach and the beginning of the duodenum and enter the pancreatic duct or the bile duct with catheters and use X-ray, what you see here, to perform interventions. The two most common treatment that we do for pancreatic cancer patients is treatment of jaundice, which causes yellowness of the skin and yellowness of the eyes. And we typically place stents or straws that can be plastic or metal, and to open up the obstruction. As Dr. Stucky mentioned, in the past, we used to try to avoid these because we would have higher complications and sometimes we contribute negatively to the patient. But with time, we have gotten better and patients are waiting a lot longer before their surgery. So it almost has become standard of care to perform these kind of drainage procedures to relieve the jaundice, improve nutrition, and improve the healing process for the patient. The other condition that we treat with this procedure is cholangitis, or infection inside the bile duct. Symptoms of cholangitis include abdominal pain, fever, and then jaundice, or change in the color of the skin or color of the eyes to more yellow or orange in color. The urine also typically changes to darker or orange in color. Now, when we place stents, these stents can also fail, and the symptoms will recur, whether it's jaundice or cholangitis. And I want to give a clinical pearl here that is often missed in practice, is after stenting, when you get an infection, the symptoms are very subtle, and it's rare that the patient will have all the symptoms of infection, which is fever and pain. And sometimes the symptoms are very mild, and we typically see the patients go to the emergency room and have a diagnosis either of flu or some viral infection for weeks before people figure out that it's really the infection in the bile duct or cholangitis that is the source of the patient's symptoms. So if you're a patient who had an intervention on the biliary tree in the past, and you have non-specific symptoms or a sudden rise in your liver function tests, you have to think of an infection in there and discuss with your doctors if you need to be seen by a gastroenterologist. So as I said, stents will relieve the obstruction by creating a continuity in the lumen. There are two major types of stents: plastic stents and metal stents. For the main bile duct, which is a large duct, we typically use metal stents. For smaller ducts that are obstructed inside the liver, we more often use plastic stents. There are pluses and minuses to plastic versus metal. Plastic stents tend to get clogged more often, so we routinely change them every 2 to 3 months, but they can be changed indefinitely. Metal stents tend to be, we call them permanent stents because often they're not removable, but sometimes they can be removed. They, however, do not work indefinitely, and eventually symptoms of obstruction or infection can occur, and people have to be have a high index of suspicion when they have stents for any of these problems. Now, the next thing that I want to address is luminal stenting. Stenting, as you can see here from two major companies in the United States, is a metal mesh that is placed on a catheter that we can pass through an obstruction and then withdraw the catheter and allow the stent to open, and that creates a lumen that reestablishes the continuity in the GI tract. Here's an example of what we expect and what we see with obstruction. So if you see the cancer here blocking the duodenum, the appearance of the duodenum will change from this open tube to an area that is blocked like this, which we see on endoscopy. When we give the patient contrast, as seen here on the image on the right, the contrast is white. Contrast will fill up the areas that are open and will not fill up the areas that are blocked because the pressure will not let the contrast sit here. So you'll see a pattern of obstruction that is like this. And what we do is we pass a wire through the area of obstruction and pass the stent over the wire and open up the stent. And typically what we see immediately is an area where the stent is compressed like here. And as the stent open, it will have this appearance, an open stent, and this appearance here. So it will transform a blocked area into an open area, and then the patient would be able to eat again. And typically, the patients will have some improvement in their symptoms within 24 hours, and it can take up to a week to see an improvement. Sometimes with the stents taking some time to open, or the stomach taking some time to recover. Now, the next topic that I want to cover is endoscopic ultrasound guided interventions. And what is endoscopic ultrasound? We're all familiar with ultrasound that we use on pregnant women to see an image of the baby inside the womb. So ultrasound is technology that allows us to see beyond the surface. And endoscopic ultrasound combines the advantage of endoscopy, being able to enter inside the body, with ultrasound. And so we are able to image and see beyond the internal lining, beyond the mucosa or the internal skin of the body. We're able to see other organs such as the pancreas. And because the pancreas, as I showed you, sits in the middle of the body, endoscopic ultrasound have evolved to be an important tool in helping patients with pancreatic cancer. For example, this is a CT scan, and you see this round structure here. You can see much higher resolution of this structure when we use endoscopic ultrasound. Typically, the endoscopic ultrasound is placed here, which is the stomach. And so you can have very high resolution magnified images of the structure that you're looking at. This is, again, an image of the pancreas, and the pancreas sits inside the body. And this is how close is the ultrasound probe to the pancreas, basically sitting on the pancreas, which allows us to do interventions safely without having to traverse multiple organs, gives us better images and more resolution and better visualization of the pancreas. Some of the things that I'm going to talk about is now the ability to obtain biopsies from the pancreas. Because endoscopy uses small tools, in the past we would be able to obtain only cells to diagnose the pancreas, but now we can get biopsies. Biopsies allow us to do more with the tissue. So I'll cover a little bit a relatively new technique called organoids development from biopsies. We can also do EUS guided pancreatic ablations for small tumors, especially neuroendocrine tumors. We can help patients with pain with endoscopic celiac neurolysis. We can also perform gastrojejunostomies to relieve gastric obstruction, and we can also drain the gallbladder in patients whose gallbladder are infected, where surgery would not be a good option for them. So first, in the last, I would say 10 years, we've improved on the technology, and now even though we use small needles with endoscopy, we're able to obtain biopsies of the pancreas. And if you go back 20 years ago, this was almost unheard of, and to get biopsies of the pancreas, you'd have to go through the skin, which has higher complication rates, so it was rarely done. But now, because we're able to obtain cores, we're able to get real histology as opposed to cells. We're having better diagnosis and more accurate diagnoses, and we're able to obtain enough tissue to do genomic testing early, which would allow the oncologist to tailor treatment, especially if they want to consider unusual treatment, or what they call targeted therapy, which is therapy based on the genetic makeup of the tumor, not just the source and the histology of the tumor. The benefit of being able to do that with endoscopic ultrasound is you're able to do it on tumors in the pancreas, as opposed to metastases that have already spread, which allows you to analyze and get this analysis early in the course of the disease. And this has allowed the development of a technique called organoids for pancreatic cancer, for example. We know that pancreatic cancer, as Dr. Stucky showed, is associated with a lot of fibrosis around it, or what's called as a desmoplastic reaction. And sometimes this is difficult to differentiate between fibrosis or cancer, and it can also create a buffer or a protected zone for the pancreas, which makes chemotherapy difficult to reach. In many other cancers, they can test chemotherapy on cells grown in the lab and know if it's going to work for the patient before they give it to the patient. This was not very readily available for patients with pancreatic cancer, but is becoming more readily available because we can create organoids or organ-like structures from pancreatic cancer to try to test chemotherapy on them early. Some of the advantage for that is after creating the organoids, you can mimic a little bit that fibrosis that you have over the cancer, and your testing is more accurate in terms of the response. For example, this is a study that has shown that if you test patients via organoid technology on certain chemotherapy, and you find that they are effective in the lab, then the patients tend to live longer when you use this chemotherapy versus when you use a generic chemotherapy. And the ability to do that with endoscopic ultrasound allows you to get this tissue early, so you have this information early and potentially could downstage or be ready if the tumor progress and know what you would be dealing with, and potentially avoid using chemotherapy that is not effective for the patient. The next topic I want to cover is radiofrequency ablation. And radiofrequency ablation is a probe that uses heat to basically burn the tissue, and it causes necrosis or cell death via direct cooking of the tumor. This is mostly used now in patients who are not good candidates for surgery, and it's mostly used in very small tumors because there's a limit as to the zone of treatment that we can perform. And because the pancreas is difficult to access through the skin, it is available through endoscopic ultrasound. For example, in a small study that looked at patients with rare tumor called insulinoma, it's a tumor in the pancreas that secretes insulin. After this treatment, in 24 hours, many of the patients' insulin level normalize, indicating that the likelihood of killing the tumor with no significant adverse events, as opposed to having a major surgical procedure and having to deal with the adverse event of surgery. Again, this is a very small study, and this is not considered standard of care now, but it is a potential option that will probably be more and more explored in the future. Now, moving from heat-related ablation to chemical ablation, we use celiac neurolysis, or destruction of the nerves around the celiac trunk, to help with pain. The major vessel, which is the aorta, where sometimes pancreatic cancer involves that artery, like Dr. Stucky showed, also causes involvement of a plexus of nerves, or a bundle of nerves around the artery, and that can cause a lot of pain for the patient. And with endoscopic ultrasound, we can go very close to the area and inject things like alcohol and numbing medications to help with pain. There are very conflicting studies on this area, but most studies have shown that it can be effective in 50 to 90% of patients in helping with pain and decreasing the use of opioids. And typically that intervention lasts 3 months. It can have some serious adverse events, but the adverse events are rare. And most of the times it can be performed safely, and can be also repeated when, if effective the first time, but the effect wear off with time. I showed you stents for management of stomach obstruction. The next topic I'm going to talk about is a technique that is being more and more used to help relieve stomach obstructions. We know that surgical relief of obstruction in patients who are severely malnourished can be risky, and it can take time to heal. It is, however, much more durable than endoscopic stenting. Sometimes getting the patient over that hump can be challenging. Stenting have evolved specifically for these patients to try to improve them and sometimes get them to surgery. However, many patients do not end up getting for surgery and require repeated interventions and more stenting. So stenting can be effective in 90% of the cases, but over half of the patient end up needing another intervention. This is an endoscopic technique that was developed in the last few years using stents that we call our lumen opposing stents. And what we do with endoscopic ultrasound is we go into the stomach, push the catheter with cautery into the small bowel, and then deploy the stent that, again, will create an opening or a lumen between the stomach and the bowel further down from the pancreas where the obstruction is. This technique is one of the more recently introduced procedures in endoscopy for pancreatic cancer. It has a technical success rate in people who are expert in it of over 90% and a serious adverse event of 6%. And an intervention, repeated intervention needed is in around 10 to 12% of the patients, as opposed to 50% with stents. This technique is trying to mimic surgeries by providing the faster recovery you see with endoscopy, but with durable effects of surgery. It's also lower cost than surgery. And as I said, has similar effect to stenting, but more durable and less need for re-intervention. This technique is not currently performed in all the sites. I showed you in where the gallbladder sits next to the pancreas, and sometimes the duct that empties the gallbladder, the cystic duct, is compressed by tumor, which causes infection in these patients. And sometimes patients who have advanced cancer are very poor surgical candidates. They have ascites or fluid in the abdomen that makes interventions through the abdomen risky and being associated with the risk of the wound being under pressure and opening or having infections in the fluid. The lumen opposing stents that I showed you that we use for creating a connection between the stomach and the small bowel can also be used to create a connection between the gallbladder. Like you see here, we put it in the gallbladder and then open it into the small bowel and drain the infection. This is used in patients with acute infection from blockage of the cystic duct. And you see here the gallbladder gets connected to the small bowel and the infection drains. The alternative to this would be draining the gallbladder through the skin, a procedure that tends to be very uncomfortable for the patient. And also because the drains that they use to drain the gallbladder are small, they tend to cause more cloggage and more problems for the patient. This procedure can be a definitive treatment for the patient, where often no other repeated interventions are needed. But sometimes when the patient survive a long time, the repeated interventions might be needed. So as I said, technical success rate is over 90%, and clinical success occurs in most patients, and only around 2 to 3% will have recurrent infections in the gallbladder requiring another intervention. Now, one more thing I want to cover is EUS-guided tumor injection of systemic agents using some newer techniques called nanoparticles. Again, pancreatic cancer often prevents locally advanced, where successful surgery can be difficult or unlikely, and the tumor microenvironment protects it from systemic agents. So we often have to use high doses of chemotherapy to be able to kill the tumor with more toxicity and less efficacy. Nanotechnology has been tested and seems to improve the local dose of chemotherapy when delivered through this technology, and decrease the systemic effect, because a higher dose of chemotherapy is developed directly into the tumor. When used with endoscopic ultrasound, it also potentially can have the effect of shrinking the tumor and transforming a patient from non-surgical to a surgical. And preliminary studies on it are very promising. This technology is being studied, so it's not widely available, and more research is being conducted and is needed before it can be widely adopted. But this is something to watch out for in the near future. So in summary, endoscopic interventions for pancreatic cancer provide multiple options, and the options are expanding. It does provide fast recovery. There's no need to hold systemic therapy or anti-cancer therapy while doing the procedure. It is increasingly becoming more effective, but still is not without drawbacks. It's often less durable than surgical interventions and does not provide cure like surgery can provide cure. And a therapeutic endoscopist like myself has become an integral part of the multidisciplinary cancer team. And I consider it a privilege and an honor to be able to work with other cancer providers like Dr. Pinella and Dr. Stucky in helping these patients. And thank you again for this opportunity.
Thank you very much, Dr. Kachaamy. And if I can ask the panel to come back, so do you mind stop sharing your screen? Wonderful. So I think we have some very, very pertinent questions that I'll try my best to I'll try my best to sort of kind of go through. So please keep the questions coming. We have about 10 minutes for questions. Some of these were answered in the chat box, in the Q&A box, so you can look at that too. But maybe I'll start with Dr. Stucky. One of the questions that came up is chemoradiation. How does that differ from chemotherapy by itself or radiation by itself? And when do you typically suggest we do it? I know you're not an oncologist or a radiation oncologist, so you're perfectly suited to talk about it.
Oh no, I am an oncologist, just a surgical oncologist, lest we not forget. So chemoradiation is actually a term I actually had to look up in my fellowship. So I feel very happy to be able to tell that. So radiation is, what we know where we get kind of zapped and the tumor gets zapped, but chemotherapy is actually given at the time of radiation too. It's not the same chemotherapy that people think of that makes you really sick and really tired and things like that. It's actually a specific type of light, I call it chemo light, lighter chemotherapy that is given at the same time as the radiation, and its specific goal is to enhance the effects of the radiation. So it actually helps the body take up the radiation more. So that's what that means. And then I typically try to give it after the full strength chemotherapy was completed and before surgery, because you want to be able to have a target for that radiation to reach.
Wonderful. The next question, Dr. Kachaamy, we talked a lot about stents, and obviously stents play a big role in alleviating symptoms, improving quality of life, especially in patients with pancreatic cancer, and it's something we do on a daily basis. So one of the questions is sort of how well do these work, and what can patients expect? Let's say they come in with jaundice and they're getting a stent for jaundice. What should a patient expect? How well do they work?
Yeah, so when successful, which we tend to be successful in 95% of the cases, typically it can take anywhere between a few days to 4 weeks for the jaundice to completely resolve, sometimes a little longer, depends on how bad the jaundice was before we start. And if someone's bilirubin, which in normal is less than 1, is 20, it will take longer for it to go down to normal. But they are extremely effective in the short term. In the long term, if we look at for plastic stents more than 3 months, or for metal stents more than 9 to 12 months, then they will tend to fail and the symptoms will come back. And this is why with the plastic stents, we routinely change them. In things like gastric outlet obstruction, they're also more than 90% effective. Sometimes it takes time in gastric outlet obstruction for the stomach to recover and for the symptoms to go away. And it depends on how bad the worse the symptoms are before we start, the longer it takes for the patients to see the clinical improvement.
Pretty cool. Somebody mentioned that they see a colon glow behind you, so that's pretty cool. Good observation. So I think one of the things that's a takeaway in terms of what we can offer from an endoscopic perspective is that many of these really lead to an improvement in quality of life, quality of symptoms. So you really should discuss that with your doctors and be able to, hopefully be available. So moving on from a patient perspective, Dakotah, I think you did answer this, but maybe you can give sort of a Cliff Notes version of nutrition and diet after surgery. And I'll also ping that back to Dr. Stucky of how she sort of, counsels her patients after, both before and after surgery. But maybe Dakotah, you can go first.
Yeah, I had lost considerable weight before surgery because I had become food averse. I had basically had pancreatitis for almost 6 months from the time my initial diagnosis up till surgery. My tumor was so large that it obstructed both the primary and secondary ducts. So I was just in pain at all times. And so I ended up, basically, we would try food, and what didn't work, we would set aside and we would try it again in about a week, maybe 2 weeks. And it got to the point where I was down to basically tuna and popsicles were about the only things that I could eat. After surgery, however, we began to try to re-expand that. And at this point, 2 years out, I can eat most things, but it took a long time. I had to see a nutritionist. I saw her quite regularly. I food journaled. We kept track of things, some things that we thought maybe what's continuing to give me issues weren't, because when you food journal, you find out that maybe it's the thing you ate 12 hours prior or a day prior that's really triggering that pain, and it's not the banana or the piece of chicken or whatever it may be. So it was really just diligence that worked to make food and dietary choices more palatable, because you become quite food averse.
Yeah, that's good. Dr. Stucky, what conversations do you have with your patients about pre and post surgical diet and nutrition and what to expect?
That's an excellent question. I like to see all patients first, even before they start chemotherapy, because of this specific reason. A lot of patients are going to already show up with dietary problems, just like Mr. Perry did. And it's really important to me that their nutrition is as optimized as possible going into surgery. And I don't want them going through 6 months of chemotherapy, struggling during that time to be even worse at the time of surgery. So whenever I meet with patients up front, I do a very detailed history if they've been having any food fear like Mr. Perry had, if they are intolerant to specific foods, if they're losing weight, and what kind of stools they're having. Because a lot of times when you have blockage of the pancreatic duct, you also have pancreatic insufficiency. So you may be able to eat, but you might not be able to absorb. And if anybody is struggling with any of those things, we'll start them on pancreatic enzymes to help them absorb. We will get them involved in a nutrition meeting and continued nutrition and dietitian care. And then I continue to see them multiple times throughout their course of treatment to ensure that they are getting better. As far as after surgery is concerned, we counsel them just like about the same things that Mr. Perry experienced, that there might be some delayed gastric emptying, and that, it may take even, I tell my patients usually up to a year before they get back to normal, but obviously for some patients it can take longer than that.
Yeah, I just want to follow up. I think both of you made an excellent point, and there are a couple of questions about pancreatic enzyme replacement therapy. So these can be very helpful. And so as a pancreatologist, I do see patients after surgery and before surgery. And I think 2 points I will make. One is that when you do see a nutrition, I think that not all nutritionists or dietitians are very experienced in the care of patients who have had pancreatic surgery. So you really want to be with someone who has experience with that, because there are some nuances to how these are managed. And pancreatic enzyme replacement therapy or pancreatic enzymes are often forgotten. This is really undertreated in the setting of pancreatic surgery. So maybe if you're having loose stools or if you're having abdominal discomfort, things like that, bring that up with your physician, with the nutritionist. And many times, there's also what we call a mixing problem because of the plumbing is not as, has been rerouted, right? So many times, one of the practical tips that I give patients is to actually open the capsule and mix it with some applesauce and have it so that it's sitting there. So that's a practical tip that you can take home. Because many times you take the pill and you eat and it doesn't mix very well. So that's an important thing that you can take home. I know we're running out of time, so maybe we'll do one or two more questions and wrap it up. One of the things that maybe for Dr. Kachaamy is, where do you see, I'll ask a general question. The question was about drug-eluting stents for GI indications, but I'll sort of ask a more general question of, where do you see the field evolving? How are we going to help patients endoscopically more and more, maybe over the next 5 years?
Yeah, I see the field evolving into, like, I'm not an oncologist, but Dr. Stucky is an oncologist. I see the field evolving into, endoscopic oncology, where we become a more specialized team that joins the oncology team instead of being on the outskirts and being able to deliver things like chemotherapy or immunotherapy endoscopically, specifically to the tumor, or performing ablations like I showed you that will make an impact on the patient in a minimally invasive way. So as if you go back 50 years ago, there were surgeons, not surgical oncologists. So now we have therapeutic endoscopists, but I see the field evolving into more specialized, into endoscopic oncologists.
And
Excellent question.
I think that's a great point. I think the technologies are going to evolve. I think that drug-eluting stents, just to answer the specific question, have been studied. They just haven't hit prime time yet. So there's a lot of work going on drug-eluting stents. Cardiology obviously has solved that problem to a degree, but I think there's more to come on that. So I think that there is a lot of technology and technical expertise that is building up that really, I think, will help our patients. And I think maybe I'll end by one of the very important things when we talk about pancreatic surgery, which I think should be talked about, and I'd like to get both the patient and the surgeon's perspective on this, is how do you choose a center? How do you choose your surgeon? And it's a loaded sort of question, but maybe can you give some general guidelines? And I'm sure, Dr. Stucky, you're asked about this by your patients. So what sort of conversations do you have?
Yeah, I was kind of hoping to go first because I want Mr. Perry to have the final word on that, because I actually think it's most important to hear it from the surgeon or from the patient, right? So from my standpoint, you want to go obviously to a reputable person. You want to go to a place that has good outcomes, has high volume, and just somebody that you can trust. That said, I usually tell people to be cautious if a surgeon wants to jump into the surgery right away, because that doesn't necessarily mean that they're considering all of the things that need to go up to the surgery in advance. So that's my personal opinion. High volume has been shown to be better for patient outcomes, but ultimately it's going to be about who you trust and who you feel comfortable with.
Yeah, I think that's a great point. Dakotah?
Those are the exact things we targeted. So we had experience with our local university medical center with my wife's mom, who had dealt with this disease about 5 years before I was diagnosed. It's a high volume center. The same surgeon that did her surgery did mine. So we were very familiar with needing to be at a place that was experienced with this surgery, because it's just such a big surgery. So knowing that they had that experience, it was, for us at least, a no-brainer. There really wasn't anywhere else local that would have been capable of giving us the same type of outcome.
Wonderful. I think that's a perfect segue. And I think, I apologize if I can't get to maybe one or two questions I haven't been able to get to. So, but this has been a wonderful sort of panel discussion. I really appreciate everyone's input. I really want to take a minute to thank Trish O'Neill from the National Pancreas Foundation for organizing this and getting that. And I really want to put a plug in. The National Pancreas Foundation, of which I have the privilege to be a member and be involved with, really has amazing resources and questions like, how do I pick a surgeon? How do I pick a center? There's the Centers for Excellence that are listed on the National Pancreas Foundation website. So I think there are extensive resources, and so please check that out. One of the things, I'll tell you a story, all my patients love the cookbook that the NPF puts out for the pancreatitis patients. So things like that, there's plenty of resources. So I'd really encourage you all to take a look. So any final words, Trish?
I want to thank the panelists and Dr. Piniella for chairing this event for us tonight and moderating for us, and for Dakotah for you sharing your personal story. I think you can see based on the questions how engaged the audience was. So thank you all so much. And Dr. Kachaamy and also Dr. Stucky, we really appreciate it. And for the audience, if you have further questions that we can try to help answer for you, please feel free to reach out to the Pancreas Foundation at info@pancreasfoundation.org, and we can try to direct you into a facility or to a doctor that might be able to assist you with your questions. So thank you all for joining us this evening.
Thank you. Good night.
Thank you.
Thank you.